Good evening, everybody.
Good evening. Hi, I was wondering if you could post the slides
I've posted them.
because I just tried to download them, but they weren't available.
They're posted.
Try to refresh. Thank you.
Did you find them?
Yeah, I just refreshed. Thank you.
Okay. We'll give it till about 5 after and then we'll get started. Give people some time to log on. We'll give it till about 5 after and then we'll get started. All right, let's go ahead and get started. If y'all can mute yourself, because we're hearing some backgrounds. So tonight we're gonna talk. I'm Dr. LePage. Sorry about that. Tonight we're gonna talk about lethal and emergent cardiac rhythms. So for our learning outcomes, we're gonna identify the lethal cardiac rhythms that can lead to emergency situations or death. Identify the components of the EKG waveforms and how those apply to the patient's conditions. Identify the medications and treatments used to restore cardiac perfusion and then normal EKG rhythms. That's our goal. And then discuss the ACLS algorithms and treatments of patients post cardiac arrest or upon return of spontaneous circulation. So, one thing I just want to mention, ACLS is advanced cardiac life support. Everybody working in the healthcare field has to be BLS certified, and I'm sure you all are already. But ACLS is reserved for those nurses that are working in specialty areas, and not necessarily reserved. Anybody can take the course, but you cannot administer any of those life saving medications unless you've had that certification or that course here in the United States, at least. So, we're going to just review a little about the basics of identifying EKG rhythms. You want to ask yourself 4 different steps. Is it regular or irregular? Is it fast or slow? And then is there a P wave for every QRS? And then is that QRS wide or bizarre? And the reason we are going back to this is because we've talked about a lot of atrial rhythms in the previous sessions. And the atrial rhythms, there's always an abnormality with the P wave. And your QRS complex is always narrow because,
Hello,
like I
Professor. Hello, Professor. Sorry for interrupting. Please kindly share your screen.
I thought I was sharing it. Okay, I'm sorry. Let me go back to it. Can you see it now?
Yes, thank you, ma.
It's funny when I log on and share it, it doesn't always stay. So thank you for telling me. I have to once I start the session, I share it immediately, but apparently it goes away, I guess. I don't know. So thank you. So back to our steps, and when remember if we talked about our atrial rhythms, our QRS is always narrow, and I kind of equated that to our atrial rhythms have the narrow QRS, and because they're smaller, right? Remember the atriums, our atria and our atriums are smaller, and the ventricles are more serious. A lot of our atrial rhythms are not lethal or deadly rhythms, where in contrast, our ventricular rhythms are. So when we're talking about our ventricular rhythms, which most of our lethal rhythms are, our QRS is going to be wide. So definitely knowing the definitions like we talked about, and we'll go through some more definitions when we talk about these rhythms here. Remember your 6-second strip method to calculate the heart rate. You're going to count the heart rate, your QRS beats, and then you're going to multiply it by 10. Sinus rhythm, remember, and I'm reviewing this because this is important when we talk about pulseless electrical activity. We're going to see that electrical activity on the monitor, but the patient is not going to have a heartbeat, which is why we go back to that old saying, we treat the patient and not the monitor, because we need to identify whether this patient has a rhythm or not. And we'll talk about that a little more. But remember, in sinus rhythm, we have a P wave for every QRS. The rhythm is regular, which means those QRX complexes are going to map out. And it's not fast or it's not slow. It's normal. It's between 60 and 100 beats per minute. And then the QRS is narrow. And that's a normal sinus rhythm. When we talk about ventricular tachycardia, that's going to be an irregular heartbeat. It does stem from the ventricle, and it's typically greater than 100 beats per minute. Those ventricles are stopping from being filled with blood, so they're not able to pump out the blood. So when we talk about our patients in ventricular tachycardia, they're going to have a decreased perfusion because that blood is not getting pumped out. If you look at the rhythm strip right there where it says ventricular tachycardia, and we go back to our steps, is there a P wave for every QRS? Well, we can't identify that P wave. It's in there, but if we slow that rhythm down, we'll see it, but we're not able to see it. What stands out in our ventricular tachycardias is that the QRS is wide and bizarre. It is a regular rhythm, but it's an irregular arrhythmia. So when we map out those QRSs, that's going to be a regular beat. It could typically be greater than 100. And those ventricles, the most important thing to remember is those ventricles stop filling. So the blood is not going out to the peripheral. So when we do an assessment on this patient, they're going to have lack of perfusion to those tissues and that peripheral. The episodes of VTAC can be brief or they can be prolonged. And a patient can be in ventricular tachycardia and have a heartbeat, and they can be in ventricular tachycardia and not have a heartbeat. And we treat those in two different manners. It is considered a medical emergency no matter how long the episode is. And we are getting the pulse, and our goal is to try to restore that rhythm to a normal rhythm. If we have a pulse with this patient, that's our goal. If the patient is pulseless, we're going to treat it like ventricular fibrillation, and there's nothing. There's no perfusion, there's no heart rate, there's no nothing. So that's why it's very important that we check a pulse on our patients and check our patients and not just the cardiac monitor. So risk factors for ventricular tachycardia. Underlying heart disease. A lot of times if these patients have had previous MIs, heart attacks, that could cause it. Digoxin toxicity can cause ventricular tachycardia, and digoxin itself, whether they're toxic or not, long-term use can cause ventricular tachycardia. And I'll give you an example. This occurred to me. I have heart failure from the birth of my twins almost 24 years ago. And it was an acute episode of heart failure, but it's considered a diagnosis of mine, and I get monitored and treated every year. I was put on digoxin 23 years ago and did well. Had no episodes, no recurrent heart failure. I've been stable. I'm one of the lucky ones, and the cause of my heart failure was from the pregnancy. Therefore, when I delivered the twins, the heart failure became stable. So I was on digoxin about 5 years ago, and I was going for stress tests every year. And about 5 years ago, I went for my every yearly stress test, and I started seeing VTAC on the monitor, and then I felt it. So we had to obviously stop the stress test. I had a good 63-second run of ventricular tachycardia. They got me off the treadmill. Once they got me off and sat me down, thank God it stopped spontaneously and I had no further episodes. Of course, I had a whole cardiac workup, got admitted to the hospital. They did everything, but the only thing they could contribute it to was digoxin. I was not toxic. My digoxin levels were within normal parameters. I was having no signs of digoxin toxicity. And when I actually researched it a lot more in depth, because now it happened to me, digoxin and long-term use can cause ventricular tachycardia without toxicity. Thank God I've been off of it and they put me on a different medication and I have been fine ever since. Hope and pray to God that I stay that way because that was not a fun experience. I can treat my patients with it, but I don't want it. It's one of those rhythms I don't want. So anything that's greater than 60 seconds is considered sustained VTAC. And we'll talk about the different types, the polymorphic and the monomorphic. And some of our medications, particularly digoxin, causes the polymorphic, which means it's very irregular looking. And we'll talk about that. Sometimes severe electrolyte imbalances can cause ventricular tachycardia. And unfortunately, illicit drug use can as well. Does anybody have any questions so far? We're good. So, some of the causes, again, are that previous heart attack, a structural heart disease, such as cardiomyopathy or your coronary artery disease, or if patients have some valve problems, QT syndrome, which is that prolonged QT syndrome. And that is where we see these patients who develop sudden these young kids playing ball and football, like the football player. I don't know if any of you heard several years ago, one of our U.S. football players fell out on the field and went into cardiac arrest. Fortunately, he was very lucky. He survived, but it was attributed to that prolonged QT syndrome. Sometimes some congenital disorders that go undiagnosed until patients become adults or older, then they see, and it can be that QT syndrome. We talked about electrolyte imbalances, particularly your potassium, magnesium, and sodium, side effects of medications, and then stimulants. One thing that is popular, I wouldn't say popular, but young kids are doing, and they probably shouldn't be, is they're drinking Mountain Dew with energy drinks and they're mixing them together. They're getting triple and double effects of those stimulants that's leading to ventricular tachycardia. And then it can be idiopathic, which means they have no explanation for it. They have no idea why it's been caused, but then they treat it. The symptoms can be chest pain. Angina pain can also cause it. These patients might feel dizzy. They might feel the palpitations. When I had that run, I did feel palpitations very hard, and I became very lightheaded and was hard to take a deep breath. Unfortunately for me, I did not have a syncopal episode or go into cardiac arrest. But those are some of the things that can happen. Oftentimes, when we find patients coming into the emergency room, they've had a syncopal episode. When they're put on the cardiac monitor by EMS, they're found to be in ventricular tachycardia. So here's where we're talking about the types of ventricular tachycardia. It can be monomorphic VTach, where each of those beats look the same. And that's in about 70% of the cases. And that rhythm strip right there, you can see they all look the same for the most part. Polymorphic is where each heartbeat is different. And that's what's typically caused by various medications or some of your illicit drugs. Non-sustained VTach is where it resolves back to a regular rhythm within about 30 seconds. The sustained VTach is when it lasts more than 30 seconds, and these patients have a higher chance of developing ventricular fibrillation. And me being a ER nurse for over 30 years and my whole career being in critical care and cardiac care, I knew that. So imagine how scared I was right at that moment. So polymorphic VTach looks like kind of like this. When we talk about our 4 questions that we ask to identify a rhythm, you see it's still going to map out. That rhythm is still pretty even, but it's changing. The waveforms are changing. So that's what makes it polymorphic. Non-sustained is where we see it. This is your lead. This is your lead 2, and you can see it comes and goes. And it doesn't last more than 30 seconds. It's definitely under 30 seconds. And then our sustained VTach, this is your EKG waveform, and this is your lead 2. And you can see it's pretty much sustained. It's there, and it's not stopping. So non-sustainable versus sustained VTach. Non-sustained VTach lasts less than 30 seconds, where your sustained VTach is going to last more than 30 seconds. Your non-sustained patients in VTach may be asymptomatic. It is often harmless, and they do often convert themselves back to a regular rhythm. Whereas your sustained, these patients may become dizzy, they may have a syncopal episode, and they may go completely loss of consciousness and then develop sudden death. Your non-sustained is typically due to your structural or electrical heart issues, and your sustained VTach is often related to a structural heart issue or a thrombus, which is starting to occlude, and the patient hasn't developed VFib yet. There's typically no treatment for that non-sustained VTach in that immediate episode, but they will get a complete cardiac workup and they may be put on medications. Your sustained VTach, it is treated with emergency medications, and often we have to cardiovert these patients by applying that electrical activity. Remember, cardioversion is less joules and less energy than the defibrillation. I know that's a lot of information in like 15 minutes. Any questions so far?
Hi, sorry. So you for in this situation, for sustained, are we defibrillating or are we using the cardio version?
If they have a pulse, we are cardioverting them.
Cardiovert. Okay.
Yes,
Thank
ma'am.
you.
Yes, ma'am. We're using synchronized cardioversion. So we diagnosed it. Oh, sorry, I did not fix that. This should be ventricular tachycardia. Let me do that for the next one. So sorry. We do a lot of symptomatology. going to do an EKG. Once the patient is stable, they may get an echocardiogram. If they have a pulse, we are going to cardiovert if they are symptomatic. And if they're pulseless, we're starting CPR and we're defibrillating. And we're going into our ACLS protocols. Think about the priorities of these. How do we know if we're going to cardiovert a patient or if we need to do CPR on them? What are we going to assess?
Like their pulse?
The pulse, absolutely. The pulse rate. Yeah.
Can you please go to the couple of slides above? I just want to look into a slide.
Okay. Once we're finished with this one, I'll go back to it.
Thank you.
I kind of lost my train of thought. I'm sorry.
I'm sorry.
That's okay. So if we're pulseless, we're going to start CPR. That's the emergency. And we're going to get that defibrillator. Do we need to wait when we talk about pulseless VTAC and VFib, we say we have to defibrillate right away. Do we wait for that defibrillator before we start CPR, or do we start CPR?
You start
Start
CPR.
CPR.
Start CPR.
Start CPR.
Absolutely. Now, which slide did you want me to go back to? The person that asked me to go back, which slide did you want to go back to?
Two more slides up. Mommy. Yeah. Yeah. And the non-sustained. Mommy. Yeah. Okay. Yep.
So
thank you.
if you're taking pictures of these,
Mhm.
that's fine. But you can go on the American Heart Association website,
Mhm.
AHA.com, www.aha.com, and you can actually look at rhythm strips on the computer and you can identify them and take practice tests.
Oh, thank you. I will do that. Yeah.
So treatment for VTAC, again, it's going to be different. If they have a pulse, we're going to give them some antiarrhythmic medications. And it depends on if it's an emergency right away. If they're coming into the ER with sustained VTAC or a VTAC with a pulse, we're going to give them some amiodarone. And I have a couple slides on amiodarone in just a minute. Amiodarone, flecainide, and Rhythmol are all medications that patients can be on PO. Amiodarone and lidocaine we can give IV. Years ago, lidocaine was the drug of choice for ventricular tachycardia. The amiodarone came about probably in about the last 15, 20 years. However, there are so many side effects and so many interactions with amiodarone that we still treat some patients with lidocaine. Flecainide is a PO medication because oftentimes these patients who have runs of VTAC, we need to treat them to make sure that they're not having any more. Flecainide has a lot of side effects, one being swelling. So if you have a patient, which flecainide is what they put me on, however, it caused a lot of swelling and ankle swelling. Well, I have a history of heart failure, so you don't want extra swelling and fluid around your ankles and your lower extremities. So sometimes there are different classes of antiarrhythmic medications. There's class 1, 2, 3, and 4, and it depends on, they each work differently. So amiodarone, if we're giving it for a patient with a pulse in an emergency situation, we're giving 150 milligrams IV. Whereas if the patient was pulseless and we're doing CPR and we've already given them some epinephrine, amiodarone can be used as well as an antiarrhythmic. But we give it after we've given 3 rounds or 3 doses of epinephrine. An AICD is an automated internal cardiac defibrillator. So if a patient is in VTAC and keeps going in and out of VTAC, where they have episodes of it, they may need to have that automated internal defibrillator placed inside of them. It is just like it is a defibrillator, so it's going to shock them out of that abnormal rhythm. And it's also a pacemaker. Most of them are dual. So again, the joules are not going to be as high or as intense as if it was outside the body, but these patients still feel those shocks and those cardioversions to get them back to a regular rhythm. When we cardiovert a patient, if we have time, we will give them some sedation. Unfortunately, it depends on how symptomatic they are and how poorly they are, how poor their condition is, whether we can give them sedation or not. If we have a patient with pulseless ventricular tachycardia, it means there's no perfusion, there's no pulse, and we identify that because we actually palpate that carotid pulse. We treat it as ventricular fibrillation. We start that CPR, we defibrillate, and we go through those ACLS protocols. Any questions?
No question.
So here's a slide on amiodarone. It's going to decrease that excitability of those cardiac cells. So a patient who is in ventricular tachycardia is going to have a very excited heart, right? We use it for VTAC and any of our ventricular arrhythmias. You can see all the contraindications. Now, when we talk about contraindications and a patient who is almost on the verge or has cardiac arrested, we got to weigh the benefits and make sure they outweigh the risks. So patients in cardiogenic shock, we try to avoid it if these patients are bradycardic, because remember, if they're already bradycardic and we're trying to give them a medication that's going to decrease the excitability of those cardiac cells, we may put them into asystole and then we have no rhythm if they're bradycardic. So we need to watch. Same with cardiogenic shock. If they have no perfusion or low perfusion to begin with, we don't want to give them a medication that's going to decrease that excitability of those cardiac cells, which means it's going to then lower the heart rate. It's going to possibly decrease the perfusion because we've lowered the heart rate too low. We don't want to give it with pregnant or lactating women because it can be harmful to the fetus. It is contraindicated, especially the PO, the pills with grapefruit and grapefruit juice. Ensure that the RN reviews the list of medication interactions. So I started to put a few of them on here, but the list is, there was at least almost 100 medications that amiodarone interferes with. So you really need to look at the benefits and see if they outweigh the risks when we're giving it to this patient, discuss it with the doctor, and hopefully the doctor discusses it with the patient. When we talk about the dosages, if our patients are in VTAC with a pulse, which means they're somewhat stable, we're giving them 150 milligrams IV. If the patient is in VTAC, which is pulseless, we're treating it as VFib, and they're getting a higher dose because remember, they're already dead. They have no perfusion, no heart rate, no nothing. You can't get much deader than dead. So we're giving them that higher dose. And then we follow it with an infusion. There is a max dose on that infusion, and it's 30 milligrams per minute. And then for PO, it's 800 to 1600 milligrams per day in several divided doses. It could be twice or 3 times a day. And then these patients are going to take it for about 1 to 3 weeks until they have a sustained, restored cardiac rhythm that's normal, as in sinus rhythm, which is hopefully. So if we give the IV push medication, we are going to start these patients on that IV infusion afterwards. And once we go from the infusion, they're going to go home on the PO or be transitioned to that PO in the hospital before they go home. So take a look at some of the side effects. A lot of risk of fatal toxicities, hepatic toxicities. So what are our nursing interventions for that? We want to monitor those liver enzymes. We want to do a good skin assessment or assessment of the patient to ensure that they're not developing any jaundice or any signs of liver problems. Possibly palpate the liver and check to make sure it's not becoming enlarged, which would be a sign of liver failure. Proarrhythmic effects, which means it's going to increase or worsen the original arrhythmia. So as nurses, we need to be monitoring that by keeping them on the cardiac monitor, assessing that cardiac monitor and the patient, and making sure that what we see on the monitor is what we're then assessing on the patient as well. Pulmonary toxicity. So patients who have asthma or lung disease, it's used in caution. These patients can develop a hypersensitivity pneumonitis, which is a type of allergic reaction that's going to cause inflammation to the entire body and the lungs. So think about if this patient has a cardiac issue, now we're giving them a medication that's now potentially going to cause a lung issue. There goes our breathing and our circulation on our ABCs, right? Interstitial alveolar pneumonitis just means it's deeper in the lungs. And it's going to seem to occur in those patients that have previous lung infections and lung conditions. The pills can cause a cough. These patients complain of painful breathing. If they take a deep breath, they say it hurts. Some complain of numbness and tingling to the extremities, tremors, uncontrolled walking. They can develop weakness to those extremities, and then dry eyes and dry, puffy skin. They can develop blurred vision, and they complain of seeing blue and green halos around lights when they look at them. A lot of sensitivity to light and sensitivity to cold and heat, as well as nausea and vomiting. So to combat some of these, as far as our nursing interventions, we might want to give it with food, educate them to maybe sit up to alleviate some of the respiratory issues, tell them to be careful or have the family help them if they're having numbness and tingling and difficulty walking. We want to provide safety for these patients. Make sure we're reviewing the side effects and monitoring for any of those. If we're giving it PO, if we're giving it in an emergency situation, we don't necessarily need to check the heart rate and the blood pressure because it's an emergency. We already know what it is, right? But if we're giving it PO, we need to check that heart rate and blood pressure before we administer it. We want to manage any of the particular side effects these patients are having and definitely educate them on the medication. Again, no double dosing on this because these patients can become toxic. And so good education, especially with our older adults, about taking it as directed and then monitoring their skin color. Any questions on that? I don't know why that keeps doing it. It did it last night too. Any questions so far?
Prof, good evening
Yes.
from here. Thank you so much. My concern is about the side effects. If you should administer a drug and the side effects occur, which are expected, do you have to worry about that?
So again, you're going to look at the side effects that the benefits are going to outweigh the risks. So your risks are going to be your side effects. And anytime we, think about what medications we have, those side effects, every medication has a side effect. But in particular with this medication, that's why it's used so cautiously. But we definitely need to be monitoring these patients to make sure that we're recognizing some of these toxic effects early on so that they can be treated or they can be taken off that medication. If we're talking about an emergency situation, again, those benefits are going to outweigh the risks. If we don't give a life-saving medication, what's going to happen to the patient? They're going to die, right? Or potentially die. And in this case, they might. There are other medications that they can use. That's why it's a conversation between the patient, the doctor, and the nurse as well. As nurses, we can advocate for our patients. Did that help?
Yes, it did. But my question, I think is probably if you are given if you administer amiodarone to a patient, the patient develops nausea and vomiting, which is an expected side effect of the drug. Do you have to worry about it?
Do we have to worry about nausea and vomiting? Well,
yes. I mean, like unexpected side effects of a drug. If it happens, do you have to worry about it?
Are you asking me in a context of a particular drug or this drug?
Well, this drug.
So, nausea and vomiting is pretty much a side effect of every medication. If you look up just about every medication has a side effect of nausea and vomiting. So, that would be one of the least ones. So, I would probably educate the patient to take it with food, or I would administer it to them after they've eaten to manage that side effect. Me personally, would I worry about that? Not necessarily, because nausea and vomiting has never killed a patient. When I do a lot of my pharmacology lectures, I talk about the side effects, and even though they're uncomfortable, think about nausea and vomiting has never really killed a patient. Breathing would be an issue, or if it put the patient in cardiac arrest as a side effect. But there's things we can do. We can administer it with food. We can possibly ask the doctor for some antiemetic medications if it's severe vomiting.
Thank you.
Professor, for this
Yes.
medication, nausea and vomiting is expected, right? It's like
Right.
side effect that is expected, right?
Right.
Okay, we should not worry about expected side effect, right?
Right. But there's things as nurses we want to do to manage those side effects. So we know this medication is expected or could possibly cause hepatic toxicity. So what are we going to do as the nurse to monitor that? That would be a bad side effect, right? But we know and we manage side effects. And how do we find out about these side effects? How do they know about the side effects? Well, they see them during the drug trials. The patients that are taking these medications during the drug trials, if they exhibit a side effect or if they exhibit an untold effect, it's listed as a side effect. So I'm not real I'm not real sure what you guys are asking in relation to that. Do we worry about it? It's never harmed anybody, but do we want to make the patient as comfortable as we can and manage and monitor those side effects? Absolutely. Did that help? Did I answer your question?
Yes.
Yes.
So this is a little overview of amiodarone. The generic name or brand name is called Pacerone. It is a class 3 antiarrhythmic, and it's going to help treat or prevent those arrhythmias and cardiac arrest. It works to prevent that electrical excitability, that overproduction of excitability of the heart tissues. The arrhythmias are going to be those disturbances in the rate. So remember, with ventricular tachycardia, it's fast. In the rhythm, remember, it's an abnormal rhythm. That QRS is wide and bizarre, so it tells us it's a ventricular rhythm. The common side effects you see there are just what we talked about. Long-term use can develop lung damage and then sinus bradycardia or other arrhythmias. And then optic neuropathy, which would be blurred vision that could possibly lead to blindness. Memory loss and confusion are going to be your central and peripheral nervous system side effects. So that's kind of a schematic. I kind of thought I'm a visual person, so I like to give you guys some visuals as well. So I hope that was helpful. It kind of breaks it down a little.
Yes, thank you, boss.
So our treatment is going to be for our unstable VTAC with a pulse. We're going to do cardioversion. And what are some steps with cardioversion? We're going to manage the airway, breathing, and circulation. And we're going to do synchronized cardioversion. I tried to find a clip that will show synchronized cardioversion, and I could not get it to load and then move over to the NAXLEX site or upload it. So when y'all go to your clinicals or when you get in the hospital, talk to one of the nurses and have them show you. They can turn the defibrillator on and put it in the test mode, and you can see the sync button. And it's going to give you either an arrow on that R wave, or it's going to give you a dot above the R wave. That way you know it's in the sync mode. And again, we use less amount of joules, and that's the amount of electricity that is being delivered through that defibrillator machine. It's the same machine that we defibrillate a patient with. When we cardiovert a patient, we put it in the sync mode. If we do not put it in the sync mode and we try to deliver an electrical shock to a patient, we are now going to put this patient into VFib because it's electrical activity. So it's very important that you know what you're doing and that you follow those ACLS protocols and that you become ACLS certified before you start doing any of those interventions. Treat those underlying causes, and we call them the H's and the T's. because there's a cause for this. What caused this abnormal rhythm? And we'll talk about the H's and T's. So your H's are hypovolemia, hypoxia, hydrogen ion, which is acidosis. It could be metabolic or it could be respiratory. Hyper or hypokalemia. Remember, we talk about that so much that your lab results, even those high normals and low normals, can then put a patient into some abnormal cardiac rhythms. And then severe hypothermia. Your T's are going to be toxins such as your medication toxicities or illicit drug use medications, cocaine, and some of your stimulant medications. Cocaine is a big component of young men having heart attacks, along with the energy drinks and then the cocaine that they're using off the street. Cardiac tamponade, and that is where the heart is not able to pump because there's too much either blood or fluid around the pericardial sac. A tension pneumothorax, both tamponade and tension pneumothorax are commonly seen in the presence of trauma, most often car accidents. And then thrombus, whether it be an MI or a pulmonary embolism. So here's a little visual of your H's. Hypovolemia, it could be fluid volume loss. Well, it is fluid volume loss in the circulatory system. It could be from many reasons. It could be from severe hemorrhage. It could be from severe dehydration. It could be from sepsis or hypovolemic shock. Our treatment is going to be fluid resuscitation. Whether it be, hopefully, we're doing it before this patient develops a cardiac arrest. And we're definitely going to do aggressive fluid resuscitation if during the cardiac arrest, if that is the cause. Hypoxia, where they're not getting enough oxygen, and that could be due to any number of things. We want to make sure that we're getting them ventilation, so we're probably going to be doing the bag valve mask and doing the ambu bag, calling respiratory, making sure we're giving them 100% oxygen and getting them on the ventilator as soon as possible. Hydrogen ion, your acidosis. We're going to get those ABGs to determine whether it's respiratory or metabolic. If it's respiratory, we're going to get them intubated. If it's metabolic, we're probably going to give them some sodium bicarb to neutralize that acidosis. Hypo and hyperkalemia, again, remember both high and low potassium can cause cardiac arrhythmias. We want to look at our EKG. And then we remember we never, ever, ever, ever push IV potassium. It always needs to be mixed in 100 mLs of fluid, and we run it through the IV through an IV pump. Any questions on that? NCLEX, mix it with the ones that is not side effect to confuse. I'm not sure what you're meaning by that. I'm assuming that's back when we were talking about side effects.
Hello, Professor.
Yes.
Please, what are the alternative drugs that those that have lung issues can use instead of aminoderone? Like those that have
I can barely hear you.
Okay. I am asking, I said, what are the other alternative medication that those that having maybe asthma can take instead of taking aminoderone, since it's not lungs friendly?
Well, it can cause lung problems. But if this patient is in ventricular tachycardia, it can just exacerbate the lung problems. So they can take amiodarone. It's not contraindicated because we just know that those are side effects. So we need to just monitor the patients. And again, we use it cautiously, and the benefits are going to outweigh the risks if we're giving it to a patient. But again, that's not the nurse's call. That's a doctor call, a physician call. But we as nurses need to be aware of it and need to know that maybe the physician doesn't know about it or know that this patient has an underlying condition. Did that help?
Yes, thank you, Professor.
Okay. The last cause of our H's could be hypothermia. So we see that a lot in cold with patients who develop frostbite and patients who are out in the elements in some of our colder climate areas. We want to warm these patients. Put the warming lights on in the trauma room. Most of our trauma rooms in our facilities have warming lights. May be hot for us, but we need to warm this patient. Get the blanket warmer. I'm sorry, get the bear hugger, which is the warming blanket for the patient. We need to treat that hypothermia and get that patient's temperature up to normal temperature, or as normal as we can get it. So again, managing those H's. If it's hypovolemia, we're going to administer fluids, fluid boluses, or blood products. Hypoxia, we're going to oxygenate or intubate. Hydrogen ions, those acidosis, we're going to administer sodium bicarb if it is metabolic. And if it is respiratory acidosis, we're going to intubate. Hypokalemia, we're going to administer that potassium. Hyperkalemia, if you look at the chart that I put there, you see mild or moderate. If it's moderate and this patient is in VTAC, we're going to be given that glucose and insulin and sodium bicarb and possibly that albuterol. And then hypothermia, we're going to warm the patient. Our T's are our toxins. Most common causes are toxicity to our tricyclics, digoxin, beta blockers, and then the calcium channel blockers. They say, I mean, cocaine used to be, but now with some of these other street drugs that are out there, and the synthetic fentanyl that they're mixing in a lot of the street drugs here in the US, we're seeing a lot more patients come in with ventricular tachycardia due to some of the street drugs. So we're gonna look for the signs to see what medication we can identify, if we can identify it. And then if there's an antidote, administer that antidote. If it's our opioids, we're going to definitely give them Narcan. Cardiac tamponade, remember, it's that fluid buildup in that pericardium, and it results with the heart is not able to pump the blood out to the peripheral. So a pericardiocentesis is gonna where it actually withdraws the blood out. Again, that's not a nursing function, that's a physician function. And then a tension pneumothorax is is where the shifts in that intrathoracic pressure and it causes a collapse in the lung. A needle decompression is what needs to be done, or a chest tube. Again, those are physician or highly trained individuals. Some facilities, depending on where you are, nurses can perform needle decompressions with special training. A thrombus, which would be either your heart attack or your pulmonary embolism. So if it's a heart attack, a massive heart attack, we need to get them to the cath lab for that percutaneous coronary angioplasty, where we get that stent in there and we open up that artery so that the blood flows. If it's a lung pulmonary embolism, we might need surgical intervention, or we can do fibrinolytic therapy, the clot busters in the emergency room. So just an overview, management of those T's. If it's toxins, we're going to administer the antidote if we know it, if we can. We're tamponade, we're going to assist the physician with that pericardial centesis. If it's a tension pneumothorax, we're going to do, if we're trained, the needle decompression. If not, assist the physician. If it's a cardiac thrombus, get him to the cath lab for that PTCI. If it's a pulmonary, we're going to administer that fibrinolytic, that clot buster medicine. It's most often the alteplase. Any questions? No questions? Okay. So let's talk about ventricular fibrillation. Basically, this patient is dead. They have no heartbeat. They have no blood pumping. It's a very chaotic rhythm. And you can see on that rhythm strip below, no blood is pumping out. This patient is basically dead. It requires immediate intervention, that CPR and that defibrillation. Most often it's caused by an MI. What can cause it? Patients can go into VFib if they have severe cardiomyopathy. Again, previous heart attack predisposes them into having another one. Sometimes some genetic disorders. Sometimes some heart medications. A lot of electrolyte imbalances and electrical shock. Also, lightning strike can put a patient in ventricular fibrillation. So one of the things about lightning strikes, these patients, the first thing we need to do if they're not in VFib is get a EKG, because somewhere along the way, that lightning shock is going to interrupt that electrical shock of that heart. So these patients can have some temporary loss or some permanent loss and death. I have a scenario. There are several lakes in the city that I live in, and it was probably about 8-10 years ago. There were two gentlemen on the bank of the lake fishing. There were people on the lake in the kayaks. A thunderstorm came in very quickly. Lightning was striking. The border patrol, the people that monitor the lake, I don't know what they're called, but they were out on the water getting people off the water, and these two gentlemen were standing under a tree. The lightning struck the tree. It hit the first gentleman first. He went completely into cardiac arrest, and it ricocheted off of him and hit the second gentleman. The second gentleman had no sensation, had a temporary paralysis from the waist down, which is a common thing that we see with lightning strikes. And unfortunately, the first gentleman that got the direct hit that went down right away was in ventricular fibrillation when EMS got there and they attempted to shock him. Another thing that I learned, I took an advanced burn life support course a couple years ago. And what I did not realize is that electricity, and I mean, it makes sense once you think about it, but if you get an electrical shock, we don't know where it's burned on the inside of the body, because that electricity, that shock, can go anywhere in the body and it doesn't follow any particular path. So unfortunately, the first patient did not survive. The second patient, by time EMS got him downtown, because I live in outside a metropolitan city, and the patient needed to go to a trauma center. By time EMS got him downtown, he had regained the feeling in his leg, and he had no subsequent disabilities from that. He got to live to tell about it. There's actually a plaque on the tree that was struck, and you can see where that lightning was struck in memory of the patient that died. So, taught me a lot about electricity, and I stay clear away from lightning anytime I see it. Drownings can cause ventricular fibrillation, and then, unfortunately, drug misuse and overdose. Sepsis. How do we diagnose it? We can't palpate a heart rate, right? And when we put them on the cardiac monitor, we see chaos. These patients often collapse, so that's an indication. They're probably unconscious. And again, we see that chaotic rhythm on the cardiac monitor. So treatment for VF is going to be CPR, defibrillation. We use epinephrine, and we use the epinephrine that is diluted, and it comes in Bristol-Jets. Again, it is a ACLS medication that we use. And then we can also use the amiodarone after we've given 3 rounds or 3 doses of epinephrine. Continued CPR, and then identify the cause. Again, those H's and T's can be causes of ventricular fibrillation as well. And then treat the cause if we're able to identify it. Complications: if we get a patient back from ventricular fibrillation, they may have an anoxic brain injury. It depends on how long they were down or without blood flow. Post-defibrillation arrhythmias. Again, remember, we're giving this patient electrical activity and an electrical current. So it may place them into some other arrhythmias. Injuries from CPR and resuscitation, they may develop some cracked ribs. The pads may burn their skin. They may have some long-term disabilities, as evident from whatever the cause was, or if these patients are, we've seen multiple times, especially in all my years working in the ER, we see patients who are driving. Did they have a heart attack before they crashed, or did they crash and the crash caused a heart attack? So they may have some disabilities related to that trauma. And then subsequent myocardial injury, and unfortunately death in some cases. Any questions on ventricular fibrillation? VFib, defib. Yep, that is true. So another rhythm we're going to talk about is pulseless electrical activity, or PEA. It used to be called electromechanical dysfunction, EMD.
Prof, I have a question about the epinephrine. Does it follow? the epinephrine.
Okay.
Does it follow a time difference? I mean, time pattern, the administration, like nitroglycerin, where you administer for 1 minute, then when there is no improvement, then 5 minutes time you administer.
Yes. So epinephrine in a cardiac arrest is every 3 to 5 minutes. And I have, depending on the situation and the cause of the cardiac arrest, we have given, it depends on how long we're working the patient, to try to get them back. We have used up quite a bit of epinephrine.
Okay.
So it's every 3 to 5 minutes. Has anybody witnessed a cardiac arrest or a code situation?
No.
I don't know why that is doing it. Nobody's seen a code?
I see the code, but it was in my house. It was my mom.
Oh my gosh, I'm so sorry.
Yeah, it was.
I've seen a
When
code before.
And what did you witness? What did you see them do?
So they normally do the CPR, and then after a while they check pulse, and when there is no pulse, they continue with the CPR. And I can't remember, they normally also give the epi, and they shout out epi going, and then there'll be somebody recording whatever they are doing too.
What about the what?
There'll be one of the nurses who records the time and the medication and dosage that is being given to the patient.
Right. Absolutely. So in most of the emergency rooms, the emergency room that I work in, if I'm assigned to the trauma rooms, keep in mind a code can occur in any room because any patient can code, right? But if I'm assigned to the trauma rooms, we identify who's going to do what and we put it on the whiteboard first off in the morning. So if I'm the nurse assigned to those room, I'm considered the primary nurse. So what my role would be is I'm going to either be the person that runs the code, especially if I'm the first person in the room and see the code, or I'm going to be the one that's kind of extra and giving all the information. Our paramedics that work in the ER typically are the ones that do CPR because they're men and they're strong. Our respiratory therapist, anytime we call a code, they're going to manage the airway. We always get extra people. Each person kind of knows their role. If we have other paramedics or extra EMTs, they'll come and put the extra IV sites in. And then we always have a nurse who's going to record and a nurse who's going to give medication. So sometimes the primary nurse gives the medication as well, but you always need a recorder. Absolutely. Because you have to document what's going on. Epinephrine is every 3 to 5 minutes. We use antiarrhythmics, the amiodarone, after about the third. Those are not the only two medications. Again, it depends on what the cause of that cardiac arrest is or that ventricular fibrillation. If it's due to a heart attack, we're going through our heart attack algorithm and we're given the oxygen, morphine, nitro, aspirin if they're awake. And we're going through that algorithm as well. So the roles are kind of identified. Codes can be chaotic and they can be very controlled. Some nurses will get hysterical during a code. You have to learn to stay calm yourself. So pulseless electrical activity means these patients have electrical activity in their heart, but for whatever reason, the heart is not pumping out the blood. There's no heartbeat. Typically, these patients are in normal sinus rhythm or a sinus bradycardic rhythm. So that's what you'll see on the monitor. But when you look at the patient, there's absolutely no signs of circulation. So they're going to be pale, they're going to be blue, you're going to check a pulse and you're not going to feel a heart rate. They can be due to your H's and T's, can also cause pulseless electrical activity. So again, treating those H's and T's that we talked about. Signs and symptoms of PEA: absence of a palpable pulse. These patients are more than likely apneic, cyanotic. They could be in respiratory acidosis. They could be hypothermic, electrolyte imbalances, hypo or hyperkalemia. They could be due to hemorrhage or loss, so you may see a lot of bleeding. You're going to see no signs of circulation like we talked about. Hypoxia, you may see some jugular vein distension and tracheal deviation if it's due to that cardiac tamponade or that tension pneumothorax. The treatment is going to be CPR, treat that cause, epinephrine, and the ACLS protocols as well. So one rhythm that right before I realized I did not put asystole on here. Asystole is a flat line. There is, again, no heartbeat is going to be found. You're not going to be able to palpate a heartbeat. Most of our cardiac monitors in the United States, years ago, we used to have to check the monitor, obviously you check the patient, but if it was some electrical problem with the monitor or a lead was off, it would look like asystole. Now they've made monitors, and most hospitals have it, where these monitors, if a lead comes off or if it's a malfunction of the cardiac monitor, you're going to see dotted lines versus that flat line. If the patient is flatlined and in asystole, the only treatment, we do not defib, we do not shock asystole at all. What we do is CPR and epinephrine, and we try to identify the cause and treat the cause of it. Once a patient is either found in asystole or develops to asystole, there's not a good chance of survival of they may survive that cardiac arrest, but they may not have any blood flow and they may have some anoxic injuries to the brain and not be able to have spontaneous respirations. Any questions? That was your mom's case. The paramedics saved her life. Good. Paramedics are great. I have lots of friends that are paramedics.
Hello, Professor?
Yes.
Please, is there any difference between this PEA and the heart block?
And what?
And heart block. What's the difference between pulseless electrical activities and heart block? PEA and heart block. What's the major difference?
I'm not sure what the last thing is. Can
you
spell it?
An heart block. He said, what's the difference between the C?
I'm not sure what. I can't make out the last thing. I don't know what that is.
Just say heart block.
Heart block.
Oh, heart block.
Yes.
Okay. Yes, there is a big difference. Yes, there is. I'm sorry, y'all. I'm having a hard time hearing. Heart block and PEA. So yes, there is a big difference between heart block and PEA. PEA is pulseless electrical activity. A heart block, that means There's no blood perfusing, but we have electrical activity. That, remember that conduction system from our first class or our first session on EKGs? We have a pumping part of the heart and we have an electrical part. So PEA, the electrical part's working, but the pumping part is not. In heart block, we still have a heartbeat. It's sometimes very low and sometimes very low perfusion going to the peripheral, but they still have a heartbeat. And they're still, most often, we need to do something, especially in third degree heart block, but we treat them differently. They have a heartbeat, so we're not going to do CPR on them. Does that help?
Yes, thank you, Professor.
I'm sorry.
So,
No
Professor, what
problem.
medication you give it to them?
For which one?
Heart block she just mentioned.
For a heart block, it
Yes.
depends on the type. If it's first degree or second degree, we may need to pace these, put an external pacemaker on them, and give atropine. If it's complete heart block, we do not give atropine in complete heart block. These patients need a external pacemaker until they can get an internal pacemaker, because the heart block means there's no communication from the atrium and the ventricle, and complete heart block can lead to asystole. Yeah, pacing. Does that help?
Yes, thank you.
Okay. So, return to spontaneous circulation. That is our goal with every patient that develops cardiac arrest. Some recent statistics: our non-traumatic cardiac arrest here in the US is up to 370,000 per year. So that is a lot. I know in all my years in the ER, if we went one shift without a cardiac arrest, it was kind of good. There were some times we had 3, 4, and 5 in a day, and there were times where we had 2 at the same time. So it depends on how busy your emergency room is. We were not considered a trauma center because our trauma centers are in downtown Atlanta, but we got a lot of trauma patients as well because they had to be stabilized. 8.2% of those out of hospital cardiac arrests will obtain spontaneous circulation. So that's a very low number, right? Good CPR and good early defibrillation is what helps with that, and educating the public on how to start CPR. 21% of inpatient cardiac arrests will have return to spontaneous circulation. Post-resuscitation care begins immediately after we have that return of circulation. And how do we manage these patients? We want to continually manage those ABCs and manage and maintain that they have return of that spontaneous circulation. Avoid hypoxia and continued frequent assessments by the nurse. Some of our nursing interventions for ROSC, we're going to maintain a MAP greater than 65 millimeters of mercury. That may be, we're going to be titrating medications. We may be giving fluids. We may be monitoring, and that means we're going to have to be doing vital signs very frequently. These patients typically go to the intensive care units. Aggressive fluid resuscitation, depending on, especially if they were hypovolemic. We might have some vasoactive medications. They may be on Levophed or dopamine. Continual cardiac monitoring. They may go to the cath lab once they're stable to see why they had that cardiac arrest. They may get a CT brain to make sure they have perfusion to the brain. We may do targeted hypothermia where we put them on the ice machine. If they're put on the ice machine where they circulate and we put these big, huge pads on them, and the science behind that is that if we put them on if we induce hypothermia, it will save or spare the brain cells. Seizure precautions, particularly because we don't want these patients to then shiver. Avoid hypoglycemia, so good monitoring of their blood glucose levels. They're more than likely going to have an arterial line for that blood pressure management, especially if they're on those vasoactive medications. Maintain and manage the ventilator. Sedation possibly. Depends on how long they're on the ventilator or still unconscious. We may need to do some enteral feedings. Prophylactic DVT care. Maintain and do frequent neuro checks. And then don't forget to provide that emotional support to the patient and the family. So return of spontaneous circulation is a lot more nursing interventions than some of the lethal dysrhythmias, right? So there's no end to education. It is not that you read a book, pass an exam, and finish. I try to get my students to believe this and buy into that. The whole of life, from the moment you are born to the moment you die, is a process of learning. I still learn every day. I learn from my students too. I've learned stuff from you guys as well. So just keep that in mind. If you give me just a minute, I need to turn a light on and we'll do some practice questions. Sorry. Any questions? Any questions on any of this? All right. So a nurse is caring for a client whose EKG is shown below. The client is alert with a blood pressure of 140/83. What medication is the first line treatment for this client? So this is a question you might see on NCLEX. You're going to have to analyze and identify that rhythm, and then you're going to have to discuss the treatment. So what rhythm is this? If you go through your steps.
Ventricular tachycardia. Vita.
What is it?
VTAC. Ventricular tachycardia.
VTAC.
VTAC. Very good. So what medication are we going to administer?
Amiodarone.
No.
Amiodarone.
Amiodarone. Yep. Amiodarone. Letter C. Because it is ventricular tach, and amiodarone is that antiarrhythmic medication, right? What do we use? What do we use atropine for?
For bradycardia.
Yes, you are correct. Bradycardia. What about epinephrine? What do we administer that for?
Asystole. Asystole.
Well, we admit not just asystole. What else?
Anaphylaxis.
Ventricular fibrillation.
Okay, so we do administer it for anaphylaxis, but we administer it in a different concentration and a different route. We administer it for cardiac arrest. Somebody said asystole. We do administer it for that. Yes. We use it for a lot of different things. Anything that has to do with getting that patient's blood pressure up. And then are you asking a question?
Sorry, Professor. Sorry.
That's okay. And what about adenosine? What do we administer adenosine for?
Supraventricular tachycardia. Tachycardia.
Well, what type of
SV.
tachycardia?
Supraventricular. SVT.
Supraventricular tachycardia.
SVT. Yep. SVT. Good job. A nurse is aware that what is the initial priority intervention for a client in asystole?
B.
CPR.
CPR.
CPR, yeah.
CPR, yeah.
CPR.
CPR, yes.
Yep. Make sure you read all of the answer choices. So, do we ever defibrillate asystole?
No.
No, never. We may we may administer epinephrine for asystole, but first we got to do that CPR. Do we cardiovert asystole?
No.
No, there's nothing. There's nothing to cardiovert, right? There's nothing.
Electricity.
A client suddenly loses consciousness and collapse. The EKG is shown below. What is the priority action by the nurse?
Begin a synchronized cardioversion. Cardioversion?
I cannot see the questions. I don't know why.
Begin cardioversion. Yeah.
D.
Why?
D.
I'm not sure. Can everybody see the question?
Yes.
Yeah, because I'm sharing it. I'm not sure why you can't see it, sir.
For me, it's B. B.
B as in boy?
Yes, for me, it's the B because it's
D.
Yes.
Check for the pulse first, I think.
Check the carotid pulse.
Okay, so this could be kind of tricky. So this is what is this rhythm?
VFib.
VFib. Are we going to have a pulse with this rhythm?
Yes.
No, we are not.
No pulse.
We are not going to have a pulse with ventricular fibrillation.
So we defibrillate.
Remember VFib?
C.
We defib.
VFib immediately.
Yes, you
We defib.
You defib.
Oh,
I mean, you didn't specify, you know,
this is a C.
Okay.
Defibrillation.
Okay, if y'all give me a minute to explain and talk about why we go through this. So, if we defib immediately, we already know this patient does not have a pulse, right? Checking a carotid pulse is gonna kind of waste some time. We need to start CPR and defibrillate this patient. If the question wanted you to put it in order, start CPR, defibrillate the client, administer epinephrine. Well, I just gave it to you in that. I gave it to you in the correct order. Sorry. That's going to be the steps of treatment. You're going to start CPR, get that defibrillator, because remember, the defibrillator is not going to be in the room right away. So what do? The point of this question is that students recognize you have to defibrillate this rhythm. this rhythm requires defibrillation, okay? To get it, to shock it back into somewhat, hopefully, a regular rhythm. Does that make sense?
Yes.
Yes.
A charge nurse is educating student nurses about defibrillation. Which of the following rhythms are treated with defibrillation? So this is a select all that applies. So there's more than one answer choice.
A.
A, E.
A and E.
A and E.
A and B. Yes.
A and E.
A and B as in boy.
A and E as in elephant.
Yes. Ventricular fibrillation.
Pulseless electrical activity.
Yes.
Okay.
Pulseless activity.
So
But the D2. The D2. Supraventricular tachycardia.
okay. So let me go through them.
Yeah, I have 3. A, D, E. For me. I don't know. I'm not sure.
Okay. So
I think so.
ADE
Yes,
is
yes, ma'am.
incorrect.
Yes, Professor, yes.
It is it is ventricular fibrillation and pulseless ventricular tachycardia.
Tachycardia?
Pulseless.
Pulseless. They don't deceive us SV.
Yes. Pulseless electric
Let the
activity.
professor explain, please.
Please be patient. Let us hear.
Okay, so let you answer. Is that what you were saying? I'm trying to. So it is ventricular fibrillation and pulseless ventricular tachycardia. Remember, if they're in tachycardia and don't have a pulse, we treat it as ventricular fibrillation. We do not defibrillate supraventricular tachycardia. We synchronize cardiovert supraventricular tachycardia if the patient is unstable. We do not defibrillate. We do not add electricity to pulseless electrical activity. This patient already has electrical activity, but does not have a pulse. When that electrical conduction works, it's not producing blood flow to the peripheral. So if you were to shock or defibrillate pulseless electrical activity, you will cause this patient basically to be deader than dead. But you don't want to defibrillate, give electricity to anything that already has electricity. Does that clear it up and make sense?
Yes, ma'am.
Yes.
Yes,
Professor, what's the final answer?
A and B.
B for boy.
B for boy, ventricular fibrillation and pulseless ventricular tachycardia. Remember, the pulseless ventricular tachycardia we treat like VFib because there's no pulse.
Oh, only E and D.
Only A and B as in boy.
I'm sorry, yes, A. I'm sorry.
Thank you, Professor. And B as in boy.
Oh, thank you, Professor.
A client with the following EKG reading has a blood pressure of 89/60 and is complaining of chest pain. Which intervention is most appropriate? So what is that rhythm?
Ventricular tachycardia.
Okay.
Ventricular tachycardia.
Good. Is this patient stable or unstable?
Unstable.
Okay, so what are we gonna do?
Unstable.
Unstable.
Amiodarone.
Administer amiodarone.
The number C. Administer amiodarone.
Okay, so
Professor,
If there is pulse,
if
we
they say what
fibrillate.
we start
If
first,
no pulse, we
is that a
defibrillate.
CPR first or amiodarone first?
okay,
Amiodarone.
so this is a
Amiodarone first.
CPR first. CPR.
Think CPR.
Oh, T.
Can you
Okay.
let Professor answer, please? Thank you.
okay, so this is ventricular tachycardia, and this patient is awake and has a pulse because we know he's awake because he's complaining of chest pain. You've identified that he's unstable. We're not going to do CPR on somebody who's awake. And this patient is unstable, and we know that by the blood pressure. So we need to perform synchronized cardioversion to get this rhythm back to a normal rhythm because he's unstable. If we lose his blood pressure, he's probably going to go into ventricular fibrillation. So even though we may administer that amiodarone, we're going to synchronize cardiovert first and then administer the amiodarone. And the key word there is unstable. And we identify that because we see the very low blood pressure. His blood pressure, the map, is below 65. So he's, even though he's still perfusing, he's not perfusing well. Does that make sense?
Yes,
Yeah.
ma'am.
Yes, Prof.
So, Professor, the way you give amiodarone if the MAP is 65 and up, right?
Well, if the patient is in VTAC and stable. So he's complaining of chest pain and his blood pressure is very low. And we use the map to see exactly how low he is. So his map is going to be about 60 off the top of my head. Do y'all know how to calculate the map?
Yeah.
Systolic plus
Yes, Prof.
2 times the diastolic plus the systolic divided by 3.
Yeah, so his map is low.
Hello.
So he's unstable because he's also having symptoms. So we're gonna synchronize cardio.
Please, can you mute? Please, can you mute?
Yeah, leads him list up for gas.
Hey, guys, mute,
If we
please.
leads him job a minute.
Sorry, excuse me, Professor. Please, how do we calculate the map? I didn't get that.
I'm
I
hearing
don't
a
know that.
lot of background when you talk. What are you asking?
I said, how do we calculate the map? I don't know it.
The map.
Malgré que les dîmes que la utiliser ma
Reginald, can you mute, please?
Whoever's talking to somebody else, can you please? I'm trying to mute. It's a lot for me to mute and manage the slides. So if you guys could mute yourselves if you're having other conversations. So what was the question, ma'am?
Where you were asking about, do we know how to calculate the map? I said, I don't know. Can you tell me? Because I didn't understand it when they were saying it again.
Okay, so to calculate the map, it's 2 times the diastolic blood pressure, which would be 60. I'm sorry, that would be 60 times 2, which would be 120. And then you add the systolic, which would be 89. That makes it 209. And then you divide by 3, which makes it 69.
Thank you.
So even though he's within normal, he's still complaining of chest pain with a lower map. A nurse is reviewing the indications for synchronized cardioversion. For which of the following conditions would this intervention be appropriate? Select all that apply.
Professor, I have a question, sorry.
Sure.
What is the map? I think I missed it. I wasn't
A
there.
and E.
The map is 2 times the diastolic plus the systolic divided by 3.
How do I define it?
The mean arterial pressure.
Thank you.
So do we synchronize cardiovert unstable atrial fibrillation?
CNE.
No.
A and E.
No, you don't.
Okay, so this is synchronized cardioversion. So remember, we're syncing it and delivering joules to a patient who's awake. So we do perform synchronized cardioversion on unstable atrial fibrillation. Do we perform synchronized cardioversion on pulseless ventricular tachycardia?
No.
No.
No. What do we do for that?
Defibrillate.
We defibrillate.
Defib.
Yes. Do we use synchronized cardioversion for supraventricular tachycardia
Yes, we
that's
We give adenosine.
unresponsive to vagal maneuvers?
No.
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 Yes, we actually do, because it's
Not
synchronized
responsive.
tachycardia, supraventricular, and we're synchronizing it. This patient, it wasn't working some of our other interventions. So our answers so far are A and C. Do we perform synchronized cardioversion on ventricular fibrillation?
No.
No.
What do we do for that?
Defib.
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 Yep, we defib. Do we synchronize cardiovert monomorphic VTAC with a pulse and a patient who is symptomatic?
Yes.
Yes.
Yes, we do. This patient has a pulse. So our answers are A, C, and E. Everybody see that?
Yes, thank you.
Okay. A client post cardiac arrest is unconscious and intubated. Which intervention is most appropriate for neurological preservation? So if you're not sure about this answer choice, we kind of talked about it. Administering naloxone, that's not going to preserve their neurological status, right? Maintain a glucose above 200. Well, that's pretty non-specific, because above 200 could be 500. Above 200 could be 1,000. And we know that's not good, right? So that would not be a good answer choice. Initiating targeted temperature management. That's where we put the patients on the cooling ice, right? The Arctic Sun, which is the machine that circulates ice and keeps them. Remember, I said post cardiac arrest, it's going to help preserve brain function. And then placing the patient in a prone position. We don't put intubated patients in prone positions.
C.
We did that with COVID, but that was a specific disease process. So by process of elimination, if you weren't sure of the correct answer, we just eliminated the 3 incorrect answer choices, and the answer choice is C. Does that make sense?
Yes, ma'am.
Yes.
Yes, Professor, thank you.
Yes.
Yes, Professor. Thank you.
A nurse is caring for a client with shock refractory ventricular fibrillation. That means the shock is not working. Which drug is recommended?
Atropine.
Amiodarone.
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 Absolutely. Amiodarone is
B. Yes,
amiodarone
amiodarone.
is that antiarrhythmic drug. What do we give atropine for?
Bradycardia.
Bradycardia.
Bradycardia. Yep. So what
Bradycardia.
does it do? It's going to increase the heart rate. Well, we have nothing in ventricular fibrillation, right? Dopamine works on increasing the blood pressure, but if our patient is in ventricular fibrillation, we got no blood pressure because we got no circulation. And magnesium sulfate isn't going to help ventricular fibrillation. So our answer is B. The nurse understands that there are potential causes of PEA and asystole. Which of the following are included in the H's and T's? Select all that apply.
A, B, and C.
A, B, and C, you said?
A, B, and C.
And
A, B, and C.
Okay, so it's actually, remember, hypovolemia, hypoxia, hydrogen iron, which was your acidosis, and hypothermia. Your T's are toxins, tamponade, tension pneumothorax, and thrombus, either pulmonary or your cardiac, which is your MI. So your answer choices are A, B, C, and D. Does that make sense?
Yes, ma'am.
yes, thank you.
Yes, Prof.
Yes, Professor.
A student nurse is aware that which of the following is true about pulseless electrical activity?
B.
C.
C.
D.
C.
Whoever said D is correct. So remember, pulseless electrical activity is just that. We have electrical activity, but we don't have a pulse. So we see the EKG is going to show an organized rhythm, most often sinus rhythm or sinus bradycardia, but the client has no palpable pulse. So one of the causes could be hypokalemia, but it's not always caused by hypokalemia. B is incorrect because it's the opposite. We do see electrical activity on the monitor. And A is incorrect because we do not defibrillate that. We already have electrical activity, right?
Yes,
So
ma'am.
everybody okay with that?
Yes, Professor. Thank you.
Okay. A charge nurse is conducting a staff training on defibrillation and cardioversion. Which statements should the nurse include? Select all that apply. So we're talking about two things here. We're talking about defibrillation and cardioversion.
A, D, E.
A and B.
So I think the first person said A, D, and E.
A, D, E.
A, D.
Are you ready for the answers?
A, B, E.
So the answers are actually A, D as in dog, and E. So let's talk about B, because I heard several people choosing B. Cardioversion does require synchronization, but it's not on the T wave, it's on the R wave. And cardioversion is not used for pulseless rhythms. Defibrillation is used for pulseless rhythms. Does everybody see that?
Yes.
We're good?
Yes, Professor.
Yes, ma'am.
The charge nurse is conducting a staff training for ACLS. What is the recommended dose of epinephrine during cardiac arrest according to ACLS guidelines?
A, milligram every 3 to 5 minutes.
Every 3 to 5.
Yes. A is the correct dose. 1 milligram every 3 to 5 minutes. So if you weren't really sure about that, 2 milligrams IV bolus once. We're not going to give it once. We're going to give it until this patient hopefully comes back, right? Or we call the end of the code. 1 milligram IV every 10 minutes. That's a long time, right? We're in a code situation. We need to do it more. And if you were, or more frequently. And if you were a little confused about that 5 minutes, look at the route of administration. We're not giving it IM. We're in a code situation. Everything is going IV. After return to spontaneous circulation, the nurse is aware that which action is most appropriate.
So C?
C.
C. Yep. Go use your ABCs, airway, breathing, and circulation, right? We got to get that. We got to maintain that oxygen, that breathing, right? We can monitor for hypothermia, right? But that's not going to be, monitoring is typically not the most appropriate action when it's asking for an action. A nurse is assessing a client when they notice the following rhythm on the cardiac monitor. Which is the nurse's most appropriate action? So that is asystole. That is what asystole looks like.
D.
D. No cardioversion.
Comment est Jean-Claude? Nous là, oui.
D.
Moi, déjà, non.
So it's actually, we're going to confirm it in 2 leads. We're going to make sure that it is asystole. So you just change the lead or push the button to put it in another lead. We may ventilate with 100% oxygen, but do we really know this patient needs 100% oxygen? If it is truly asystole, they need CPR right away. We do not defibrillate this rhythm, and we do not give amiodarone because amiodarone is an antiarrhythmic and there's no rhythm. There's nothing. The charge nurse is conducting a staff training for ACLS. Which rhythm requires immediate defibrillation?
Sorry, Prof. For the last question, can we administer adenosine?
Adenosine is not going to do anything. Adenosine slows down the heart rate, and they got no heart rate. With asystole, there's nothing.
The question on the screen is C.
The answer to this one is C. You are correct. So that is all I have for tonight. I hope that was helpful. I would probably go back and practice identifying the rhythms and then figuring out what is defibrillated and what is cardioverted, and just kind of do a review on that.
Thank you.
It's a lot of information, I know.
Yes, Professor.
Does anybody have any other questions? I think
Please,
there's
with the issue with the pulseless electrical activity, what did you say we should do? Because there's already electrical activity. Did you say for them we should,
so
because there's already electrical activity, we should cardiovert?
No, you're not going to cardiovert because they already have electrical activity, but nothing is being pumped out to the body. No blood is being pumped through that heart. So how do we get blood pumping through the heart? By CPR and by medications. So we can give epinephrine to help bring that heart back. But this patient needs CPR. We don't administer electricity to anybody who has an electrical activity in their heart.
Okay, thank you, Prof.
You're welcome. How can I get a copy of the slides? They're under previous webinars on the NAXLEX website. Any other questions? Which American site did you say we can find? It's www.americanheartassociation.com. I'll put it in the chat. You can also try AHA.com. Any other questions?
Thank you, Professor.
You are welcome.
Many thanks.
Professor, please, I want to be clarified. The second to the last question, I was asking if we can administer adenosine after CPR. Sorry, after the...
So the second to the last question was asystole.
Yes.
If you admit, what do you use adenosine for? Do you know? Adenosine is used for SVT. So the purpose of adenosine is to slow the heart rate. If this patient is in asystole, they have nothing. They have no heart rate. So if we administer adenosine, it's not gonna do anything. They already have no heart rate. It could be detrimental to this patient. The only medication we administer is gonna be epinephrine.
Okay, epinephrine. Thank you.
You're welcome. All right. Well, I hope. When is my next webinar? Tomorrow night. I'm doing pharmacology.
Okay.
What time? What time, Prof?
9 o'clock tomorrow, I believe.
All right. 9 o'clock.
So
Well,
tomorrow
it's
is
nine.
the
It's 9 o'clock Eastern. So
Eastern
it's
time, okay.
listed as I think 8 o'clock on the website.
The class is the pharmacology.
Ma'am?
The class is the pharmacology.
Yes, it's pharmacology.
Yeah, what time? 9 or 8 o'clock?
It's 9 o'clock. Kelsey
Thank
put
you,
4
Professor.
a.m. Kenya time. That's early. I'm sorry.
That's okay, no problem.
All right.
No problem, Professor.
Have a good
Thank
night.
you. You too.
Thank you.